So today we will be discussing the concept of immunity. Let me share my screen and we'll get started. Now I hope that everyone has reviewed their SLOs and also did the required reading for this lecture because it'll help move the class along if everyone can contribute to the conversation. Everybody decided to come to this. Oh, I'm gonna record this class. This is the only one that I will be recording because it's all that's left. So let's record to the computer.
Recording in progress.
All right, so yeah, we're gonna record this class. So again, good morning. I hope everyone reviewed their SLOs and did their required reading because again, that's what's gonna help guide the class and move it along and help you guys learn, right? If everyone read, it could contribute to the conversation. So today we'll be discussing immunity. And immunity is the body's natural or induced response to infection and its associated conditions, and is made up of molecules and cells, tissues, and organs that seek out and destroy and damage cells and foreign tissues. So there are three lines of defense. Our first defense is skin, and when that skin is broken, you'll see the immune response in action because you'll get swelling and redness because it's trying to keep the antigen from entering the body or limit its response and limit its action. So you'll see inflammation as an example of a non-specific immunity. First, we need our skin. We need it to be intact. That's our first line of defense. And then non-specific immunity is when inflammation occurs, like all your body's defenses goes to a specific site and limit its exposure to tissue by reducing the workload on the immune system. And like I said, example of that is inflammation. And then if your non-specific immunity doesn't work, then your specific immunity will kick in. And that's when antigens that are found on the surface of pathogens, antibodies are directed toward that the body will form antibodies to fight off those antigens. So that's your specific response. And there are two types of immunities. Who can tell me what the two types of immunities are?
Active and passive immunity.
Exactly. The two types of immunity are your active immunity that occurs through exposure to the disease, like vaccinations, right? And your passive immunity occurs when you get antibodies from another person, like during childbirth, you get antibodies from your mother. So those are your two types of immunities. And so the exemplars that we'll cover today are hypersensitivity, systemic lupus erythematosus, rheumatoid arthritis, and human immunodeficiency virus, AIDS, and acquired immunodeficiency syndrome are the four exemplars that will be covered here today. And we're going to begin with hypersensitivity reactions. So there's four different reactions. There's the allergic reaction type 1, which is localized or systemic, and that's your reactions that occur right away. And that's your urticaria, your rhinorrhea, your hives. All of those are systemic reactions, your rashes. And then secondly, there's type 2 reactions, which are your cytotoxic reactions. And there's tissue specific in cases of hemolytic reactions from blood transfusions and also ABO incompatibilities. And you'll learn more about that in labor and delivery or OB. And then there's your autoimmune reactions, which are complex mediated reactions. And that's your autoimmune disorders. And then delayed reaction type 4 is reactions that occur 48 to 73 hours after the contact with an allergen. Oh, I missed this. So autoimmune responses is, so in a perfect world, everyone will be immunocompetent, meaning that their body recognizes me versus not me, and it fights antigens that, attempt to harm the body. In your hypersensitivity reactions, you get an exaggerated response or overreaction. Autoimmune disorders, your body can't tell me from not me. And with your immunodeficiency responses, you have an incompetent immune system. It just doesn't work like it should. It can't fight off basic infections that the normal person with an immunocompetent immune system can. They can't fight those diseases off or pathogens off. So in your reading, you probably read some signs and symptoms or cues. So cues of hypersensitivity can range from mild to severe. They could range from itching to shortness of breath. So you have to be astute and good with your observation to see, what do we need to do? Because all of these symptoms and your treatment are based on the symptoms. Whatever's going on is what we need to treat. The patient have itching, we'll treat that. The patient have shortness of breath or anaphylaxis, then we'll make sure we provide airway support. Has anyone seen anyone in anaphylaxis or shortness of breath or had any type of allergic reaction? And tell me what that looked like and how the treatment go. Okay, I'll tell you, like, you can see allergic reaction in any department, any floor with any patients, right? Sometimes you'll see the emergency department, they'll come in, they know that they have allergic reactions to seafood, so they'll know what kind of response they'll have. They'll come in, they'll get treatment. And some people don't know what they're allergic to, and they'll still come in. And most of the treatment is going to be, what medication are we using to treat these reactions?
Steroids and like Benadryl, diphenhydramine.
Antihistamines. Mm-hmm.
Right, so we're going to use antihistamines,
Epinephrine too.
epinephrine depends on the severity of the allergic reaction. Absolutely correct. So the mild reactions, if they come to the hospital for them, they'll probably just get PO medication. They'll get the PO Benadryl, the PO antihistamine, the PO corticosteroids, right? That's what they'll get. And if they have more severe reactions, then you'll look at maintaining their airway. However that has to happen. Is it just giving them oxygen, giving them breathing treatments, giving them epinephrine to try to maintain their airway, all the way up until maybe they'll need to be intubated, right? So what's angioedema, and what popular medication can cause angioedema?
Those would be like your Prills.
Yeah.
Your prayers, absolutely. So say you have a patient come in and they have angioedema and it started last night. Do you think it'll be as emergent or as much of a concern as if they came in and it started 10 minutes ago? Like, which one would be more concerning?
The quicker, the more acute reaction.
Exactly, the acute reaction. So what kind of signs and symptoms would you see, or what cues would you see if it was like, if the airway was compromised? Like, what would you see?
Like swelling in the back of the throat and tongue swelling.
Mm-hmm.
And the patient probably can't speak in clear sentences. Maybe they'll have drooling. Maybe you'll hear stridor because maybe the throat is starting to close. Yeah, so there have obvious cues that they're in respiratory distress. But the patient that comes in with angioedema, and she say it started last night, it didn't get worse, but it's just not going away. Those people are not as much of a concern as the ones that happen right away, the acute ones. But still, even with angioedema and the patients appear stable, they'll get an IV and they'll get all of those medicines that you named, those antihistamines, they'll get it by IV. And they'll get probably Benadryl, probably Pepcid, and also Ciumedrol will be the medications that they'll get. Because it can always get worse, even though it isn't worse. Sometimes they get admitted, sometimes they don't. It just depends on their presentation.
Can I ask a question?
Yes.
What is the reasons for the Pepcid?
because it's also antihistamine. One of them is a beta-2, it blocks your beta-2 receptors. So it's a antihistamine.
Okay, gotcha.
Yeah, another student asked that. So medicines have different uses, but the classification is antihistamine, so they'll use two. So if you know someone that, gets urticaria or hives, if they're at home, they can start taking Benadryl and they can take Pepcid or Zantac or one of those medications and it'll work. So that's what they'll give in the ER. But of course, if the lips, tongue, throat, or any of that is affected, then they need to go to the emergency department. But if it's just some itching, Benadryl and some Pepcid will help.
Are you saying Pepcid ending with a D, right?
Pepcid, yes.
Okay.
Famotidine. Or Zantac, any one of those beta-2 receptors. So we've treated these patients and now they're going home and they may get a prescription for epinephrine. So you have to do some patient teaching. What are we teaching these patients about epinephrine, the injection?
When and how to take it?
When and how to take it. So when and how do you take it?
In the, what's that muscle called? The outside of the leg.
Yeah.
Yep.
Deltoid?
Thank you.
What'd you say? Where'd you take it?
In your leg is the vastus lateralis.
Uh-huh. The lateral, yeah.
Oh, that's right. Sorry.
And if
Don't
it's
they say like blue to the sky, orange to the skin when you're pressing the blue tip goes up, the orange part goes to their body, because if they put it in wrong and they try to stab themselves, they're going to get the epinephrine in their finger and it can cause like severe vasoconstriction and their finger can fall off. I saw it on the internet one time.
I'm gonna say that's very interesting. I never heard that, but that's some good teaching if that's yeah. What are some other things? So do they have to take off their pants? Like if the pants can't come off readily, then you could stick it through the pants. And also if they have to use it, what else do they need to do?
Hold it in place for 10 seconds.
Okay, they hold it in place, but what else? After they use it, they need to go to the hospital.
Oh, yeah.
So they need to go to the hospital. So you need to tell them that. Make sure they're checking for expiration of the medication, because we want medicine that's going to work efficiently. Yeah.
If it's expired, is it going to be weaker or stronger?
Well, some people say it doesn't do anything, but they say best if used by, which means you still probably can use it, but best if used by. I don't want to say it's weaker or stronger. It may act the same.
Okay, but it's still safe. Like it's not.
Yes, I don't think it'll hurt you.
Okay.
It won't hurt you. And so you'll also see that they'll go home with like maybe a 5-day dose of prednisone, of corticosteroids. It won't be tapered. It'll just be 1 pill a day, just to make sure that that inflammation is put at bay. Any questions? So mild to severe. Oh, so what can you as a nurse do to prevent any of this from happening? Like what actions can you take on the floor in the ER, IC, anywhere you go? Like what actions can you take to help prevent some of these reactions?
Ask if
their
the patient has
allergies.
allergies before you give any medications.
Exactly. Asking do they have allergies, making sure that that allergy list is up to date, because some nurses will just click, like if they see allergies listed, they'll just move on, they'll click review, even if they don't review it, because maybe the patient has added something new. So that's what you can do, right? Making sure those allergies up to date, making sure that they have an allergy armband on. And if you give them a new medication, it'll just be a good idea to watch them for a little while after giving that newer medication. In the ER, we called it shot time. And we gave an injection, an iron injection of ceftriaxone. We would make the patient wait 30 minutes, just to make sure they don't have a reaction. Because most reactions are going to happen right away if they're not a delayed reaction. But most medication reactions, they happen right away. And so we mentioned cytotoxic reactions, that type 2 reaction in the case of blood transfusions. Have anyone seen the process for drawing blood for blood transfer typing, blood type and cross match?
I have in veterinary medicine, but I'm pretty sure that it's the same to do a type and cross match. I think the principle is the same.
What's the principle?
So, well, dog and cat blood is different. So there's different steps for dog and cat blood. So, but basically, you're making sure that the patient does not, that their blood doesn't like autoagglutinate in the presence of the blood that they're going to receive. Like it tells you, like you take the patient's blood and the blood that you're going to give, and there's like a bunch of tubes, you run a bunch of tests, but you're trying to see if there's a reaction in the tubes because it would tell you if the patient is going to react or would most likely have a reaction to the blood product.
Okay.
And then typing is like, you put it on a thing. It's like a little pregnancy test. It tells you, like, a little line comes up on what type it is. I don't know if it's the same in human. I don't know what y'all's typing looks like in
I'm
human
about to
med.
say, let's bring it back to humans. So if you have to do a blood type and cross match on a patient, every hospital, this is gonna have to happen. When you draw that blood, you have to draw it at the bedside. You should be drawing all blood at the bedside. You have to bring another nurse in the room. They'll have a separate armband that you'll put on this tube of blood, and most times it's a red tube of blood. So, and that second nurse who's verifying that you're drawing blood from the right patient and label it properly, they have the initial on that blood band that, yes, this is the patient that the blood came from, because we don't want any hemolytic reactions. So we do all that we can to cause no harm. And this is a way to cause no harm. Double check in to make sure that this blood came from this patient and making sure that the right armband is on. You'll see when you start working. So don't bring the blood to your friend who's at the desk and say, sign this for me, right? And you don't want to be the nurse signing off on something you didn't witness. So if she said, I need to do a type and cross match, you go to that room with her and you sign it on bed at the bedside that you verified that this is the correct patient. So yes, blood type is you just looking for the type A, B, O, negative, positive, and then the cross match just detects the presence of antibodies at the recipient against the recipient against the blood cells of the donor. So that's your cross match. So so has anyone seen a blood transfusion being given and how that process looks?
Only in veterinary medicine.
So again, this is also a dual sign off. So whenever you're working, wherever you're giving blood transfusions, you're going to see this happen everywhere. This is just standard across the board. 2 nurses has to go in the room. 1 nurse will be near the patient. 1 nurse will be holding the unit of blood. They'll call off the unit numbers, making sure the unit number matches the unit number on that blood band that they have, name, birthday, all of that has to be checked and double checked, and blood type. So it's always going to be a 2-person dual check off for blood. And so since none of y'all seen the blood transfusion, so what happens is you're going to get a initial set of vitals, which are going to be your baseline vital signs. And then you're going to stay in a room for 15 minutes and you'll recheck the vital signs. So this is standard stuff. So what are some allergic reactions that may occur with blood transfusions?
Elevated temp, elevated respiratory rate, elevated heart rate, and then like swelling, rash, itchy.
Right. So one of them, some of those symptoms you name are part of like a hemolytic blood reaction, the fever, the back pain, the bloody urine, all that. So that's a major complication. And the other things, the itching and the swelling could be just a reaction. When I started nursing a long time ago, doctors were giving Benadryl and Tylenol prophylactically before starting blood transfusions. And now I don't see them do that as much. But yeah, some of them are just basic allergic reactions, just itching, and some are hemolytic reactions. So what do you do if a patient begins to have back pain, chills, fever? What do you do?
Stop the transfusion.
Immediately. Stop the transfusion immediately. And you're going to bag up that blood and you're going to send it to the blood bank.
Why would they pre-med with Benadryl pre-transfusion? Because that's just going to mask the onset of your like anaphylactic reaction.
And that's probably why they stopped doing it. I think they just thought most people have basic allergic reactions, because I haven't seen hemolytic reaction in all the years I've been nursing. I'm quite sure it happens. But yeah, that's probably why they stopped doing it, to not mask the fever. probably why they stopped, you know, they live and they learn. Because I think they probably would stop in transfusion if people got rashes, and then you really don't have to stop it for that, right? That's just a mild reaction. But they don't do it anymore. I don't see it being done anymore for that reason you mentioned.
Wait, can you say that last part one more time? So the only reaction you don't stop it for is a rash. Is there anything else that
So,
is
so like-
expected?
So like itching, hives and itching is like allergic reactions that they probably would just give Benadryl for. And that's why they were giving Benadryl, just for the hives and itching, just in case they got it. So we won't be stopping transfusion for hives and itching.
Okay, thank you.
Mm-hmm. So like I said, there's allergic reactions, hives, itching, then there's hemolytic reactions where you have the back pain, the bloody urine, the flank pain, the chills, the fever. So that's a different type of reaction that you want to stop it for. So the main thing you need to know is if they have a reaction, stop it. You don't do any more pre-treatment with Tylenol and Benadryl unless somebody's seen something different. All right. All right, so different tests, diagnostic tests. So in the case of skin testing, I'll just go to the bottom. They usually do skin testing after a patient has had an allergic reaction, especially when they don't know what they're having a reaction to, because that's one of the first questions when you're doing that assessment and the history taken is, are you allergic to anything? Or did you come into contact with anything that you may be allergic to? That's going to be one of the main questions you ask to see if they know what they're allergic to. And if they don't, when they leave, they'll probably be referred to an allergist or a dermatologist or whoever does skin testing to figure out what they're allergic to. And we talked about the reasons to do the blood type and a cross match. And that's the cross matches to detect any antibodies that may interfere with the red blood cells of the donor. And this RAS test, it just checks your IgE and is increased on allergic reactions and anaphylaxis. Again, these tests really don't matter much because when the patient come in with allergic reaction, we know based on their symptoms, right? So to know that their IgE is elevated won't do us a whole lot of good in the moment. The only test that's probably needed prior to is the blood type and cross match. Otherwise, the other tests just kind of confirm that yes, they're having an allergic reaction, but we probably already know that. All right, so collaborative care. So the main thing you can do is remove the exposure if possible, or don't even introduce the exposure. If someone says they're allergic to latex gloves, don't go in a room with latex gloves. What's the alternative to latex gloves?
Nitrile.
Nitrile gloves, and they probably don't use it. I don't even think they have latex gloves anymore. But latex anything, just don't introduce it to them. If they're allergic to silk tape, use paper tape. So try to keep the exposure away from them, the allergen away from them, if possible. And if you see your patient is becoming tachypnic or rash or anything like that, or having an allergic reaction to even vancomycin or any kind of antibiotic IV, just stop it. Just stop it, right? And we talked about our medications, your immune suppressants. I know y'all talked about corticosteroids to your blue in the face, so we should know about the teaching that we need to give patients with that. So what's the teaching again? You can never get too much of it. Patient goes home on a tapered dose of prednisone. What are we teaching them?
That it can cause hyperglycemia, so like monitor blood sugars if they're diabetic. It can cause elevated blood pressure and like urinary retention, so keep an eye on that if they have like blood pressure issues. And it can cause like immunosuppression.
Yep, and do not stop it abruptly. All of those things is what you want to make sure that your patient understands. And we're going to talk about this in other exemplar, so you know that. So some stuff you're gonna need to know prednisone and side effects and immunosuppressive, which you need to teach. So yeah, that is it. Antihistamines, epinephrine, we did teaching on that. Again, for you provide symptomatic relief, itching, you giving Benadryl, decongestant, if they have rhinorrhea, so whatever their problem is, we just treat the problem. All right, any questions about hypersensitivity? The thing is recognize it, making sure you understand if it's severe. And the most important thing is gonna always be to provide airway support if it is a severe hypersensitivity reaction, just making sure you provide that airway support. Otherwise, you're just treating them symptomatically, providing symptomatic relief. And you wanna also teach them to, if you know you're allergic to something, stay away from it. Don't say, I know I'm allergic to coffee, but I just wanted to have something. No, because it may be, a minor reaction this time, but it may be major next time. So just stay away from it. Any questions? All right, I think that is the gist of, and what's the best way to maintain an open airway? What's the best position? High
Chin.
powers.
Chin up, yeah, high fivers and chin up.
All right. I think that's the gist of our allergic reaction. Keep them away from it, treat symptomatically, provide airway support. You'll learn anaphylaxis, thinking level 4, so we won't delve too much into that. Know your medications, and that is it. If you see them develop an allergic reaction, stop whatever they're getting. So we talked about the monitor the expected outcome. So if you give medication, you want to make sure that you get the desired effect from it, right? If you give epi, you expect the tongue swelling to go down, you expect the breathing to be easier. If you give Benadryl, you expect the itching to stop, or if you're giving some type of topical corticosteroid, you're expecting the rash to go down or the itching to stop. And usually it works. Usually when you give those 3 medications I mentioned, because that's what you'll see given most often, it usually works, and the patient usually goes home and they're fine. All right. So if you think of any questions later on, just put it on discussion board and we'll deal with it there. So rheumatoid arthritis, that's what we're moving on. So can anyone tell us about rheumatoid arthritis? What you read, what you find interesting? Has anyone taken care of a patient with rheumatoid arthritis that they want to share? So what is rheumatoid arthritis?
It's an autoimmune disease.
Like inflammation of your joints and the synovium, really.
Yeah, so the rheumatoid factor attacks healthy tissue, the synovium, but it has the potential to damage any organ. But yeah, mainly it is a synovium, and the synovium does what for your joints?
Lubricates them.
Move. Yeah.
All right. And so the disease is marked by remissions and exacerbations, right? And it's a chronic progressive disease, meaning it doesn't get better. Hopefully it doesn't get worse, but it just doesn't get better. It just is progressive.
I was recently diagnosed with it, but I think it came from nursing school. So
Oh no.
I should have just stayed out of nursing school, and I probably wouldn't have had rheumatoid arthritis because they said it came from a lot of stress.
Miss Patricia.
Mm-hmm.
I don't know.
I
So
think
it's
I was
hard to diagnose it.
in school.
So did you get an RH factor done?
Yes, ma'am. They
And
thought it was a toss-up between lupus and rheumatoid arthritis, but it ended up being rheumatoid.
And there you go. It's hard to diagnose lupus, rheumatoid arthritis, or any of these autoimmune diseases. It's very hard to diagnose because it affects so many systems of the body, so it's hard to pinpoint a diagnosis.
I was fine until nursing school, though.
I don't know. So what are you gonna do about it?
Well, I'm so far, I'm like on my second month of methotrexate, so it's kind of like, it's, um, it's kind of like subsiding. It's just in two of my fingers right now, so it's not really bothering me now.
So here's a good question for you since you're on methotrexate. Do you take folic acid?
Yes. So, and I've been asking because in the class they said you shouldn't be taking it. So why am I taking it?
So the thing is, because methotrexate depletes your body of folate, which is necessary. And I told that to the other class that you're supposed, and it helps with signs and symptoms of the methotrexate. And I said that in the other class, and it was like, well, we learned that you're not supposed to take folic acid. So your book says that, but standard of care is you take folic acid.
Right.
So, not taking it is not part of standards of care. So I'm glad you said that. I'm glad. Because at first I wasn't gonna mention that you need to take folic acid, but I'm glad that
Yeah.
you are on methotrexate and you are confirming that you take folic acid.
Yeah. I've been seeing a rheumatologist.
Good. I'm glad to hear it because I said that in the last class and a student, she emailed me out notes from farm. I'm like, okay.
Well, yeah, in farm they did say that, but I wanted clarity, but I didn't ask. And so, but yeah, I'm currently taking folic acid.
And you should, because it's help with signs and symptoms. I mean, side effects, and also the methotrexate depletes your body of folate, which is needed in the red blood cell production. So you take it. They don't take it on a day that they take the methotrexate. Is all I did read.
I take the folic acid every day, and I take the methotrexate only on Mondays.
And everything's been working for you?
Yes, ma'am, it is.
Good. First-hand knowledge. So yes, so this disease also affects more women than men, and typical onset is between the ages of 40 and 60. But all ages can get it. There is no cure. You just have to take your treatment, right? So patients don't ordinarily get admitted to the hospital with a diagnosis of rheumatoid arthritis. It may be a secondary diagnosis, but rarely will you find them being admitted for a diagnosis of rheumatoid arthritis. This is a disease that can be treated outpatient unless of the body symptoms are involved. Because you can have, it increases your risk of coronary artery disease. So they may come in with chest pain, shortness of breath. So it affects all the body systems. And so we had a patient a few semesters ago that was admitted with CHF, and we'll learn that opioids are not a treatment for rheumatoid arthritis. The treatments are NSAIDs and the immunosuppressants and other things like that. But if a patient is in a hospital and they're already stressed, and then all of a sudden they have a flare-up, you think that they could get opioids at that time? Would that be something that they'll get? I can't hear you, Mr.
I don't see why not.
Right, so they will. They'll get it if they need it, but it's not something they're gonna get a prescription for to go home because that's not a treatment. Rheumatoid arthritis causes inflammation and NSAIDs treat inflammation.
Yeah, it
But
doesn't work.
what does
No pain medication works for it because was prescribed some oxytens and it didn't touch it. So you have to get the inflammation down in order for the problem to go away. No medication, not even I take naproxen and it gets it down just a little bit, but really the inflammation has to go away in order for the pain to go away.
So you have to try your NSAIDs because exactly, it's an inflammatory response. You have to get rid of the inflammation or you'll still be in pain. Opiates, work on your brain. It doesn't really work on the inflammation. So, we got firsthand knowledge. All right, so some signs and symptoms. So the thing is, so this arthritis occurs symmetrically. So that's not going to be just one hand. It'll happen in both hands. It'll happen in both ankles. It'll happen in both feet. And multiple joints could be affected. at one time. And as you see, it's worse in the morning and worse with prolonged rest and strenuous activity. Would you say that's true, Miss Patricia? Is it worse in the morning?
Ma'am, because when it first started, it was in both of my arms. So I thought that it was due to the vaccination. And then it moved to my feet. And then it moved to my jaw. I went out to the dentist. I thought I had TMJ. And then when I couldn't brush my teeth, that's when I ended up going to the doctor because it was in both of my hands.
Wow, okay. So
Mhm.
yeah, and it has a multi-system effect. And so you can review that diagram on 529, how it affects all the systems of the body. But you do especially have an increased risk of coronary artery disease. And so the patient may come to the hospital with chest pain, may come to the hospital with shortness of breath, because it affects your vessels and affects your vessels around your heart. So it causes these MI symptoms, or these cardiac symptoms rather. So what are some, so here they are. So your early manifestations, you may start with joint stiffness and pain, swelling, all the way to late manifestations where you have deformity, increase in pain and swelling, muscle weakness, bone damage, immobility. So what would you teach a patient who's newly diagnosed with rheumatoid arthritis? What do you think they need to do to kind of not try to get to these late manifestations?
Physical therapy
Physical therapy,
and taking their meds as prescribed.
take their meds as prescribed. I definitely would tell them that physical therapy, take your meds as prescribed.
Hydration.
Okay, hydration.
Mhm.
Also, you want to tell them about exercise, right? You want to tell them about they need a healthy balance between rest and exercise. So what are some exercises that, oh, so diagnostic tests. Let's just go through this. Diagnostic tests. Again, there's no real test that can confirm rheumatoid arthritis 100%. So they're going to base it off these serum studies here, the rheumatoid factor, the ESR, the CRP, which just kind of tells you there's inflammation in your body. But there's no real test. X-rays just help you track the progression of joint damage. MRIs does the same thing. So there's no real test. So these are some things that you can do that can aid in the diagnosis of rheumatoid arthritis. Surgeries. Don't forget your peri-op and your preoperative things about surgeries, because all of these exemplars are interrelated on some level. So they could have the synovectomy, the arthrodesis, and the arthroplasty. But kind of remember, you want to make sure you do that during your pre-op assessment, pre-op checklist, the medicines they're not supposed to take, their allergies, all of those things still have to happen. And so after surgery, what do you want to be on the lookout for? This is just a review.
Infection, bleeding.
Infection, because after invasive procedures you get high probability of having sepsis. So yes, know about NSAIDs. We all know about the NSAIDs. All right. So what about your DMARDs and tumor necrosis factor inhibitors? What do we know about those medications?
Do these
I
like do
was
something?
curious about the DMARDs. I didn't know much about that one.
Don't these things like lower your immune system so it like stops the
The
anti?
overactivity of the immune response. So it decreases, yeah, it suppresses your immune response. So you want to talk to them about that. Don't go out in public. Make sure you're taking your pneumonia and flu vaccination. And also, when you get on this medication, you have to still take your NSAIDs because it takes a while for DMARDs to kick in. It might take several weeks, a month. So you want to make sure that you are staying on your NSAIDs until it kicks in. And so DMARDs affect your kidneys. So what might you want to monitor?
urine and
Creatinine.
creatinine.
You want to monitor your creatinine. You want to monitor your INOs. Right?
Mhm.
Yep. And so DMARDs can cause gastric irritation and stomatitis. And again, when we talked about Miss Patricia, those side effects are better controlled if you're taking folic acid. So that's one of the treatments for side effects of those DMARDs is your folic acid. Yeah. And for NSAIDs, we're making sure we tell them take it with food. If they on DMARDs, if they on corticosteroids, watch being in crowds, making sure we're using good aseptic technique when we're caring for these patients doing our hand washing, because we don't want to cause any harm. NSAIDs, corticosteroids, DMARDs. All right. Any questions? So there's a nice medication chart on 534 to 535. Now we can get to our 9 pharmacological treatments. We said we want to teach them about rest, to alternate rest with activity. Because rest and whole body, exercise and whole body rest are important in reducing the inflammatory response. So we definitely want to make sure we stress that. Make sure you know that. Alternating, right? And so what type of exercise will we recommend for these patients?
Walking.
Low impact, like yoga and stuff like that.
Right, we wouldn't tell them to go jogging and run a mile, but we definitely want to make sure that they have an exercise regimen in place to keep those joints as functioning as possible. And so when they start to be deformed, then you'll probably see physical therapy and occupational therapy on board, right? Trying to help them use their upper extremities, try to help them with their walking, because when they get that deformity to their knees and ankles and feet, it's going to be very hard for them to ambulate. So these patients in the hospital, and this is a secondary diagnosis, what else we need to watch for if they're having trouble walking?
Falls.
Yeah, safety, absolutely. They're probably going to have the fall wristband on because they're going to be taking medication. And sometimes in hospitals, they're taking opioid medication, which will put them at risk for fall. So making sure that they're not falling, making sure that what they need is near them. Like all these concepts, you just can't forget. Making sure they have a walker in place, maybe they need a bedside commode. But yes, we'll be working with physical therapy, occupational therapy, and we as nurses want to watch for their safety. And so also we'll use heat and cold. So what's the best way to use the heat?
Moist with something in between it.
Yeah, so moist heat, even a warm bath will help with their pain. And a cold kind of helps numb the pain. So alternating heat and cold is very important. And they use assistive devices like what? And what purpose would assistive devices serve? Like what
Just to
kind
help
of
them with their ADLs.
Yeah. And also you might see like wrist splints. It kind of helps keep the joint in place so they won't have as much pain. And what about nutrition? So we talked about that patients with rheumatoid arthritis have a high incidence of coronary artery disease. So what might we want to tell them about their diet and nutrition?
Low
Limit
fat.
red meat.
Yeah,
Like no red meat, and like lots of fruits and veggies.
low
High
red
fiber.
meat, lots of fruits and vegetables. And you want to make sure that essentially a cardiac diet, low
Right.
sodium, watch the processed foods, and we also want to monitor their weight. And what kind of effect can weight have on patients with rheumatoid arthritis?
It's more weight to bear on their joints.
Exactly. So teach them about maintaining healthy weight, because the more weight they have, the more it's going to be on their joints, and the worse all of this is going to get. They're not going to get out of bed, and it'll just be a terrible effect, right? They're not going to want to exercise, and then they just make things worse, and their quality of life is decreased because they can use their hands and they're not, exercising those muscles. So yeah, we want to teach them about their diet. And so nursing process clinical judgment. Again, these rheumatoid arthritis is hard to diagnose, so we have to do good patient observation and do a good patient interview and physical examination. So we're looking for that warmth and that tenderness and that swelling and that joint deformity, right? Because we have to kind of help with this diagnosis. And so here goes some diagnosis and general hypotheses. So these patients are going to have issues with pain and fatigue and self-care, anxiety, all of these different things. And role performance is going to be ineffective because remember the age that they're diagnosed between 40 and 60. And if they're primary caregivers to kids or they're the one that's working, we have to kind of acknowledge that and talk to our patients because they will have a role in effective role performance. Disturbed body image, all of these things. So the exercise and the eating, the anxiety, you might want to recommend them to support groups. Do you do a support group, Ms. Harris?
No, because I just started, but I also just started swimming, and I noticed that I've been feeling a whole lot better doing swimming, but I haven't joined the support group yet. I plan.
I see you not stopping nursing school.
Well, no, because it's the cause. I gotta finish it. If I started it, and this started with nursing school, where I ain't gonna have nothing to show for it if I don't graduate. Arthritis and no degree. So I'm gonna finish it.
You're gonna get rid of some of that stress, but this ain't one of them, huh?
But here's the thing. I never really was under any stress. I guess your body be under stress, but I never felt like I was under stress. So, but it has to me altered my life a little bit because now, like you said, in the morning it's worse because you're not moving. But during the course of the day, it's like a car. When the car warm up, I can go. So I don't let it stop me.
All right. And also, you may have some anemia. What's some side effects of anemia, and what lab results will you watch?
H&H.
RBCs,
Know what?
red blood cells, and
Your hemoglobin, yeah.
hemoglobin.
And so, what are some signs and symptoms of anemia?
General
Fatigue.
fatigue. Yeah.
Bruising.
Yeah, and pale mucous membrane, pale skin, shortness of breath, chest pain. All those are signs and symptoms of anemia. So if you just look at that systematic list and see the things that it causes, so anemia is one. And yeah, so you want to watch that hemoglobin. You want to watch that running creatinine. And this is just your planning or you're generating solutions. Like, what do we do for these patients? What do we expect to happen? We want them to have effective pain relief. We want them to be able to perform their own ADLs, and we want them to have express their feelings about their diagnosis. Again, they're going to have an effective role performance because of the symptoms of this disease. In your implementation, this is what we're going to do: treat their pain, and after you treat pain or you treat anything, what else do you need to do?
GI stuff like PPIs if they're on NSAIDs.
So if you treat pain, you have to evaluate if you have the desired outcome.
Would these patients not be on a PPI if they're on like NSAIDs regularly?
They could be, or we could just tell them to eat before taking their medicines. Or yep, NSAIDs can be taken with a PPI. It won't hurt. So these patients, we don't want to give them aspirin.
You said we don't want to give them aspirin?
Not these patients. They say because it has undesirable side effects, such as it's a narrow therapeutic window and minor dose increase can cause toxicity. Because you'll see with SLE, that's one of the treatments for SLE is aspirin. But they say with these patients and they're taking the NSAIDs, they say don't give aspirin. That's just an FYI, no worries. So take a couple of minutes and read this case study and we'll go through it, picking up those cues and generating solutions. All right, so recognizing cues. So I was just going to go over some clinical questioning with you guys. So what cues did you recognize? What are the most significant findings? And what information was less important or distracting? So what cues do you recognize?
Chest pain.
Yeah, the chest pain on the left side, the shortness of breath, dry cough.
She's not taking the ibuprofen anymore.
Mm,
So your
And
cu-
difficulty walking.
and the vital signs are all elevated except for the O2 sets.
I was just about to say, vital signs are part of it, right? So elevated vital signs. All
What does
right.
that mean? The PMHX hypertension.
Past
Past
medical.
medical
hypertension?
history. Past medical history.
Past medical history. Okay, thank you.
Yeah, sorry. All right, so let's analyze our cues. So what findings did you expect based on the client's diagnosis or concern? So what did you expect to find?
The increase, well, at least pain in her hands and feet. I mean, hands and knees. I don't know about the increased pain, but also difficulty walking.
Right, so increase in pain in hands and knees and difficulty walking. Those are expected findings. Are there any findings that seem contradictory? Like something that you just shouldn't find that doesn't make sense with,
Our oxygen thing is 98%.
you expected it to be lower?
Well, if she was short of breath, maybe, I don't know.
Yeah, everybody who's short of breath doesn't have, some people short of breath because they're anxious, you know, so everybody who's short
Oh,
of
yeah,
breath
right.
don't have low sats.
What about the
Okay,
chest?
what information can you gather to help you determine the significance of the keys?
So since she's got rheumatoid arthritis, they have a higher risk of coronary artery disease. So this could be something similar to that effect.
Very good. So what sets of cues are most concerning?
The left side
but-
chest pain that gets worse when she lays down, the cough and shortness of breath.
I think so. Very good. All right. So we're going to move on to the general hypothesis. So you recognize the cues, you analyze the cues, so the general hypothesis. So what is most likely occurring?
Heart issues from coronary artery disease, like potentially like either like a heart failure or like
A
what about
blockage.
this stuff, like almost like a acute MI, but not exactly an MI, but like a blockage of an artery that's causing the chest pain.
All right, a blockage of the artery that's causing the chest pain. Yes, ma'am. All right. What makes you say that?
Because of the chest pain that gets worse, and she's got a history of rheumatoid arthritis, and her cough is dry, so I guess it wouldn't be. Well, she's got belly pain, so what if it's like right-sided heart failure? I don't know.
Right. So, but that's how you start thinking. You start hypothesizing, like what could be happening. So, what would happen if this is not treated? So, we determined that our chest pain is our most concerning cue, and we've determined that it could be caused by damage to the vessels due to rheumatoid arthritis. But it's still an effect on the heart nonetheless, whatever, no matter what causes it. So, yes, it's our most important concern. So, what will happen if this is not treated?
She can have a heart attack.
You could have a heart attack. Even if rheumatoid arthritis is causing these symptoms, you still could have a heart attack. The vessels are still being damaged. What else could be going on besides
was gonna
MRI?
I wanted to ask that temperature is elevated, so that's like feverish. Is that expected, or is that just maybe indicate that there's an infection happening?
So do we know the signs and symptoms of rheumatoid arthritis? So that could be just inflammation. The fever could be just caused by inflammation. Yeah, so that temperature just could be from inflammation. Inflammation is what causes temperatures, right? It lets you know that your body's trying to fight something. So sometimes fever is good, but yeah. Was that your question? Tell me again.
Yeah, I was just wondering if there was like an underlying infection, but I see what you're saying.
But that
Yeah.
that could be a hypothesis. They ask what else could be going on. They do have a cough. They do have a dry cough. They do have shortness of breath. Sound like it could be pneumonia too, right? They have a temperature. So that's how we hypothesize. All right. So what hypothesis is the most important and the nurse should manage first?
The
Possible MI.
I think y'all said chest pain. Yep, we should manage that one first.
and the shortness of breath.
And the shortness of breath. And the risk for ignoring these hypotheses is the patient could have MI. So now we're going to generate.
What's that?
We're going to generate some solutions. What are the desired outcomes related to your hypothesis? Give at least two.
Like what we want our patient to be. We want our patient to not have chest pain. Is that
Exactly. We want our patients to be chest pain free, and as simple as that. And what's another one?
we want them to not be short of breath
And we want them not to be short of
and
breath.
their arthritis better controlled?
We want their arthritis better control. I want to say, don't forget that one. So yes, those are some hypotheses. So that's what we want. And so, so what interventions are indicated? So what should we be doing? What interventions?
Diagnostics, but
EKG,
EKG, chest X-ray, NSAIDs for pain,
retaking the vitals like every.
X-ray, rechecking the vitals, right? So that's the interventions. And they say what interventions should be avoided. I don't know if any should be avoided. Taking action. So we're going through the whole clinical judgment question model. Y'all can see. So we're doing clinical judgment model questions. So taking action, what interventions are needed immediately? We said EKGs, because EKGs in the ER or on the floor or anywhere, they have to be done within 10 minutes of the complaint of chest pain. What interventions can you delegate and to whom? I think the only one you probably could delegate is the EKG because techs can do EKGs, right? You could be ordering labs or calling the doctor while the tech is doing the EKG. So that's one thing that you could delegate. And so what are the mechanisms of actions of any medications and what are its major nursing considerations? So they have pain in their knees and their joints. So we want to give them an anti-inflammatory or corticosteroid. And I think y'all all know the mechanism of action for those medications and our nursing considerations. What are we teaching our patients? What should we be looking out for once we give these medications? And what's
that the corticosteroids can cause increased blood sugar, increased blood pressure, immune suppression.
All those things that we discussed ad
Don't
nauseam.
stop it abruptly.
You want to still teach that to your patient. And what information do you include in the SBAR report for hands-off and any referrals? I think
What
you
the
can
patient
include exactly
presented
what's
for.
said. And you just kind of tell the nurse what works. So you tell, oh, this is the whole report, and then you'll tell them what worked. You know, we gave her some Cocotrine, we gave her some NSAIDs, her pain was relieved. You know, and the recommendation is just to continue to monitor her for pain. All right, so now we're gonna.
Can I ask a question real quick? So it can cause coronary artery disease, sorry, but is it actually going to be causing an MI possibly, or is it just the signs of an MI? Like, are we going to be given nitroglycerin, doing that whole thing, or is that not actually what's happening?
So it can cause coronary artery disease. So what we want to do, we want to rule out an MI at this point. Because
Okay.
anytime any disease affects your heart, it could cause MIs or whatever.
So it could possibly be causing
Yeah.
that. Okay.
So what you need to do is rule it out, and that's why we're getting our EKG. We're gonna draw troponins, and we'll just kind of go through it. So you guys kind of mentioned everything that with the cues, and we talked about analyzing the cues and why she have the chest pain, and that's common for people with rheumatoid arthritis to have chest pain. But we have to always rule out MIs, right? Because it affects the vessels, like that damage is affecting the vessels, just like it affects other parts of the body. So if your heart's affected, no matter what's affecting it, it's still affected, you know. But we just rule it out at this time. So let's just get an EKG and see if we have a STEMI or a non-STEMI, and get the troponin to see if they're negative. And then if all of that's negative, then we could say without a shadow of a doubt, it's just probably a complication of a rheumatoid arthritis.
Okay.
That's why you have
All right,
to make
thank you.
that your main priority, because it's still chest pain nonetheless. Chest pain is chest pain no matter what's causing it. Let's rule MI out or in. And so
Right,
once
thank you.
once you get a negative troponin and once you get a negative EKG, okay, this is probably some effects of her rheumatoid arthritis. Then we could just move forward with that treatment. You see what I'm saying? Yeah, so shortness. So the inflammation causes pain, fever, and tachycardia. And of course, rheumatoid arthritis is the inflammatory response to autoimmune disease that causes inflammation. The shortness of breath can be just because of the chest pain. People don't like to breathe when they're having pain, right? If they have rib pain, they don't want to take deep breaths. If they're having a chest pain, they get short of breath. Could be for different reasons too, because they're not getting oxygen. And abdominal pain can be caused by taking an ibuprofen on an empty stomach. We hypothesized some things. It could be just pericarditis. It could be rheumatoid arthritis exacerbation. It could have been pneumonia. It could have been an MI. So that's some of our hypotheses. So we generate solutions. We want to reduce the inflammation and reduce the pain, and collaborate with PT and OT for the pain caused by the exacerbation. We took action. We did EKG, chest rate, troponins, NSAIDs, corticosteroids. All these things are going to happen. So after we take action, what do we need to evaluate?
If it worked.
If it worked. And how do we know it worked?
The patient's symptoms are less or gone.
Exactly. No further complaints of chest or joint pain, because we assuming that this chest pain was from the rheumatoid arthritis. The patient don't have a heart attack, none of that. And so the patient verbalized the need to eat before taking his NSAID or take a PPI to minimize GI upset. The vital signs are now all stable. They're ambulating safely, and there's no further complaints of shortness of breath. And this is what you're doing for every patient. You may have 6 patients. You're not writing this stuff down, but these are things you need to think about. All those questions, like what could be happening? What's the worst possible case scenario? When you're getting your 6 patients, that's what you think about for every patient. Who do I need to see first? Who's sickest? What could happen? You're like, what's the worst possible complication? So you know what you need to do for those patients and how often you need to see those patients. Everybody, I'm gonna say it again, everybody not going to specialty areas. There's brand new nurses right now working on med-surg floors. So when you're getting reports, you have to do these care plans in your head. You have to do this clinical judgment model in your head. You have to be, all those questions that we ask is from the National Council of State Board of Nursing, because they're saying that novice nurses are making mistakes because their critical thinking skills are not up to par. And that's just normal, not to say anything about anyone. I'm a novice educator, so my teaching is not up to par, but it'll get there. So it just takes time. Even with being a novice nurse, it just takes time. But they say if you start doing these clinical questioning, then it'll help. It'll help keep patients safe. It'll help keep you all safe. All right. So you can take a 10-minute break, and I'll see you back at 11:44.
Recording stopped. Recording in progress.
All right, we're going to continue. So with patients with rheumatoid arthritis, our nursing care is going to focus on promoting mobility, encouraging adequate nutrition, teaching patient and family about the disease process. And again, you don't teach them to not attempt activities that they can't stop immediately. You want to make sure that they don't attempt any activities that they cannot stop immediately. You want to teach them to use their strongest joints possible to complete a task. Example, use your palms instead of your fingers. And pain is a sign that they should change their action or their way of doing things. So we don't want them working through pain. We don't want to be like, oh, nurse, I'm having pain, I can't do this. Stop. Don't make them work through the pain because it'll just discourage them and they'll get upset. And so if someone can do something and they get upset, how do you think that we should respond? Like they're trying to put on their shirt and they can't do it, and you want to do it for them, but they get upset and they get a little short with you. Like, how should we respond?
Acknowledge that
that
we
it's
understand.
frustrating.
You want to not forget your therapeutic communication. Acknowledge their feelings, and then maybe we can do it later. Or acknowledge their, but just making sure that we acknowledge their feelings and understand that they're, where the frustration comes from, and it's never you. So that's it. Any questions about rheumatoid arthritis that you guys could think of at this time? No? If you think of something, just put it on a discussion post and we'll, go over it from there. We are going to move on to lupus. What do you guys know about SLE? Had any patients with lupus? Know anyone with lupus? What is it? What does it look like?
Selena Gomez has lupus.
Selena Gomez has
Yeah,
lupus.
you get the rash, like the butterfly rash a lot of times.
You do.
It's hard to diagnose also. It's an autoimmune disease.
Yeah, it's very non-specific and it can affect organs. Like it can affect your heart, it can affect your kidneys.
Your brain.
And it's like a rule out diagnosis. Like there's no like, this is a test for lupus.
Exactly. It's just like rheumatoid arthritis. There's no specific test for it, right? So it's basically based on signs and symptoms that the patient present with or whatever they tell us. Plus, there's some tests that could kind of help, but there's no specific test because it affects so many body systems. And Tony Braxton has lupus, and Nick Cannon has lupus. Lots of people, different ages, different ethnicities. But yes, it's a chronic and progressive inflammatory connective tissue disorder, and it is marked by remissions and exacerbations, and then you see the immune complexes form, the autoantibodies, or it fights itself, it fights the antibodies that the body produces. It affects organs directly, and it has an affinity for the kidneys. It affects the kidneys a lot. And there's three major classifications. There is drug-induced lupus, there's systemic lupus, and there's discoid lupus, which is limited to the skin. So how can patients prevent flare-ups?
Avoid stress.
Avoid stress. Avoid nursing school, probably. Yeah, so they could avoid stress. They could avoid reduce sun exposure, exercise regularly, and take their flu and pneumococcal vaccines. So what is the leading cause of death in patients with lupus?
Kidney disease or heart disease?
Infection, actually.
And pneumonia?
Yes, pneumonia. Infection, like pneumonia, is the major cause of death. So you want to make sure they're taking those pneumococcal vaccines. You want to make sure they're taking those flu vaccines, but eventually it's going to be infection. So the exact cause is unknown, just like the other diseases. But genetics is believed to be a part in it. It happens in more African Americans, Hispanic, and Native Hawaiians. That's what they're saying. And it's most common among women of childbearing age, and there is no cure. So back in the day, when I first started nursing, they didn't really want women with lupus to get pregnant. It was, frowned upon. They thought that they were putting the mother's life in danger because it was so taxing on the body. So they would like recommend that people didn't get pregnant with lupus. I worked at Lakeside. We had a young lady. She got pregnant every year. She had lupus, and she was perfectly fine. They just make sure you have like close follow up with your rheumatologist and your OB. So there's better medicine and more, information about it. And people are having babies. All right, so there's no cure. So I have a little video for you guys to watch.
Lupus is hard to describe. How would I describe lupus? A internal war with your own body. You feel like you have been hit by a Mack truck. Lupus feels like someone smacked you in the face. You don't look like you have lupus. People don't realize that it's painful. Physically and mentally.
Lupus is like the bully at school that you always try to avoid, but it always finds you, beats you up, and takes something away. Your friends, your energy, or even your ability to do simple things.
It's unpredictable and hard for others to see. It's like waking up every morning to your own personal game of the lupus lottery. You now have chronic pain, extreme fatigue, and kidney failure. It's hard to understand. Lupus is hard to wrap your head around. The simplest way I can describe it is the never-ending flu.
Lupus is a chronic autoimmune condition where your immune system starts to attack self. In lupus, that attack can be on any organ system in the body, which makes it difficult to diagnose. It's a chronic disease. There's no cure. It tends to target women between the ages of 15 and 45, and women of color are 4 times more likely to develop lupus.
It's hard to live with. Imagine driving a car, but your taillights are out, your tires are going flat, your parking brake is engaged, you're leaking fuel, but yet you still have to figure out how to merge onto this interstate at a high speed. You have to still do it. That's what living with lupus is like. It's hard to treat. Lupus feels like you are in a boxing match and you are blindfolded with your hands tied behind your back and you're supposed to fight. How can you fight?
It's difficult to diagnose because every patient can look a little differently. There is no cure for lupus, but there are medications out there that can help treat the disease.
Lupus is hard, but you're not alone. I get answers I need on lupus on lupus.org. 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 Lupus.org.
Yeah, so I want to show you guys that video because you saw the different people of the different ethnicities, and they tell you that you just can't pinpoint who will get it. It's most common in people of color and most common in women of childbearing age, but you saw that they had a young girl there. Some were diagnosed at 12. So you just never know. And what age range did they give on the video? It's different than a book. They gave
They said
to
15 to 40 something.
45, I think 15 or 45. And so early manifestations do mimic RA, the fever, the loss of appetite, the malaise, the weight loss, the arthralgia, symmetric polyarthritis, all mimic the rheumatoid arthritis effects. And so it will behoove you guys to know the signs and symptoms are the keys of all your disease processes, but specifically, you need to know the signs and symptoms of lupus. And does everyone know what Raynaud's phenomenon is?
Yeah, it's like where your fingers and toes turn white from like lack of perfusion.
Yes. Just want to make sure because some people miss questions on exams because they don't know what certain terms mean. So you have to know the terms. Just wanted to throw that one out there. But there's really no classic presentation. Again, that makes it harder to diagnose. But just know your signs and symptoms. And they also have anemia and hair loss too. I didn't put those up there. So these are a few tests that they will do, but no test can confirm it, but they'll do the ESR, the complement levels, and creatinine. And so for the UA, what are they looking for? And what does that tell you?
Proteinuria.
And that tells you what?
That something's wrong with your kidneys.
Kidney involvement, exactly. And they'll do kidney biopsies to kind of assess the lesions, kidney lesions, but there's no real test. And if you have kidney involvement, we already know the labs that we're looking at.
BU and creatinine.
Exactly. So pharmacological therapy. So with this, you want to take aspirin. This is one that you take aspirin because it helps with the arthritis, the fever, the fatigue, and also it helps, it's an antiplatelet. So, I don't know, with lupus, they do recommend aspirin. It's beneficial for pain, and because of its antiplatelet effects, it helps to prevent thrombosis. But it is liver toxic and
Is the reason that they would recommend aspirin is because it doesn't mess with the kidneys as much as like ibuprofen does?
yeah, and plus it has those effects of being an antiplatelet. It could cause hepatitis, but it's not toxic, right? To the liver. All right, so for skin and arthritic manifestations, they also use the anti-malarial drug. What drug is that?
Plaquenil.
The Plaquenil. So what considerations or what teaching should you tell a patient about Plaquenil?
Doesn't it cause like vision problems?
Exactly. Plaquenil causes vision problems, and it can cause, toxicity, and it can cause blindness. You need to tell the patient to have an eye exam every 6 months initially. It decreases the activity of the immune system, but you want to monitor for retinal toxicity. The topical corticosteroids treat your skin lesions. And of course, your immunosuppressants you get patients that have increased risk for infection. So while on methotrexate, you want to monitor your renal and liver functions, and also monitor their eye and nose, right? Because if it affects the kidneys, it affects their output for sure. We'll tell you down there. Use good hand hygiene. So we had a patient with SLE who was diagnosed at 17. She had a kidney transplant at 23, and now the kidney is failing. She was anemic. She had to have blood transfusions. The NSAIDs could make you anemic. Different things could make you anemic, but some of the medications can. So you have to watch out for signs and symptoms of abnormal bleeding. And we already talked about signs and symptoms of anemia in the last exemplar. Yeah, but she was all messed up. She was on dialysis. She had a very good outlook, and she was very knowledgeable about her disease process. So that's always good when they're knowledgeable and they know how to take care of themselves. So besides medication, what else can we do? And some of it is written there.
Stress management, don't smoke, eat healthy.
And so we talk about the skincare while they're out in the sun. What do you recommend when they're out in the sun?
Sunscreen or long sleeves.
Yeah, we can't just say don't go out in the sun. But yeah, sunscreen, long sleeves, sit under a shaded area. So for our assessment, we want to make sure we're doing good observation, good physical exams, and also psychological assessment, because these patients may have skin integrity, they may have a disturbed body image because of the hair loss, because of the skin rashes and lesions. So we want to take all of that in consideration, right? They're at risk for infection and we know why. So we have to make sure we're doing good teaching, good hand washing, and we are handling their IVs, good aseptic technique. You have to encourage them to eat, but also eat a balanced diet. Because when people are fatigued, they tend to stay in bed, and when you're in bed, you just want to eat. I know I do. All right, so generating solutions. Like, what do we want to happen? And they're all there. Just like we already talked about. Okay. I'll talk about steroids. We talked about all those things. Also, implementation. Taking action. We want to prevent infection, making sure they get antibiotics, making sure we're using aseptic technique, promoting good skin integrity. We talked about all of these things, managing the side effects of medicine, and providing emotional support. And how do we know our actions worked? We're going to have positive outcomes. Okay. So any questions about systemic lupus erythematosus? And like I would just say about every exemplar, I say it every time, you have to know signs and symptoms or cues. You have to know the medication used to treat the disorder. You have to know nursing consideration for those medications. If those medications affect your kidney, you need to know the labs for that. If that disease process causes anemia, you need to know the labs for that. If that disease process affects your kidney, you need to know labs. So this is how you have to think about it. Signs and symptoms. What does it cause? How do we treat it? Right? Besides medication, you want to make sure that they're exercising. You have to make sure we're giving good skin care. Tell them how to go out in the sun. So all these things that we mentioning is what you need to know. How to care for a patient with every exemplar you are covering. All right. Our last, so any questions? If you do have questions, if you think about anything, feel free to ask me and we can go over it together and I can leave a statement, so leave it in discussion post so everybody could benefit from the answer and from the question. So lastly, we're going to move on to HIV/AIDS. We have worked with actually 3 different patients on our floor in clinical that are affected with HIV and or AIDS. And yeah, have any of you worked with any patients on your floor during this clinical rotation, or seen or know anyone with HIV/AIDS? And
My mom had AIDS.
yeah, who said that?
Me, Bianca.
Okay. And so how'd that look for her? Was she complying with her medications?
No, at first she wasn't compliant at all. She got diagnosed when she was in prison, and when she left jail, she just ignored it. And it got really, really bad in like 2008, 2009. And a drug had just came out on the market called Atripla. And so she had started to see it wasn't an internal medicine specialist, and it also wasn't like an infection specialist. It wasn't infectious disease. She was something else. I can't remember what she was.
Okay.
But she put my mom on Atripla, and like my mom was like hospitalized. Like everybody thought she was gonna die. Like she was rail thin. She like looked like a skeleton. Like all of her hair was falling out. She had like sores on her body. And they started her on Atripla, and she made like a 180 complete recovery. And she was actually part of an Atripla case study because of like the extreme improvement from like literally on her deathbed to like completely normal, and then she became undetectable.
And I'm teaching people once you get AIDS. Was she ever diagnosed with AIDS? Sound like she was. Was she
Oh
ever?
yeah. She was at like she first she was diagnosed HIV, but then when she was like near death, she was diagnosed full AIDS, like with her like levels and stuff. And then that's and 'cause she wasn't on any medication at all. And then they, as she was like actively dying, they put her on a tripla, and she like completely recovered to the point where she went from complete AIDS to completely undetectable.
Now I feel like my lecture has just been blown out the water because I say once you go AIDS, there's no going backwards. Because usually that's what it is, because that's one of the things that you want to do is you want to make sure that patients don't progress.
Well,
from
that's why they put her in a paper. Like
Okay,
they,
I'm about
like
to
that,
say.
well, that's why she was like in a case study. Like her specifically was a case study for a tripla. I can't speak for other patients.
Right.
Like I don't know what their experience would be, but like she was like like she was like taken and put in like published research for
Wow.
so the tripla had just came on the market like
Wow.
maybe 3 years previous.
Well, that is a wonderful testimony. And is she still alive?
No, she actually died last month, but it was not from AIDS.
I'm sorry to hear that, though. That is a beautiful
It's okay.
testimony. But yeah, so HIV causes AIDS, which interferes with the body's ability to fight infection. The virus is transmitted through contact with infected blood and body fluids. So unprotected sex, sharing needles, and also it's passed from mother to child. There is no cure, and it is chronic. And the progression, and it has slowed a lot because of these new medications, right? These combination medications, these heart medications has slowed it. And also a lot of people are undetectable because of these medications. So when you see patients in ER, you won't see patients with HIV coming to the hospital or being admitted with a diagnosis of HIV. It's going to be either they have other disease processes going on in addition to HIV, so that'll be a secondary diagnosis. They'll come for their diabetes, their asthma, their high blood pressure, things like that, but they won't be admitted for HIV. Most HIV is managed in the clinic setting, right? So you'll start seeing them come to the hospital with those opportunistic infections, which kind of signal that, hey, perhaps this patient has AIDS. Yep, so patients are living longer and you're going to encounter them more, but you'll encounter them, HIV is going to be their secondary diagnosis. All right. And it's a virus that carries a genetic info in the RNA and can be transmitted by direct contact. So this is a little diagram of how the HIV virus replicates and reacts in your system. So yeah, according to HIV.gov, about 1.2 million people in the US are living with HIV and 14% of them don't know it. People don't want to get tested, they're scared to get tested, but if you encounter patients that think they may have it, encourage them to get tested. The treatment is, it's almost like it's a cure, but it's not a cure, but people are living longer. They're dying faster from other disease process, cancer, diabetes, high blood pressure, coronary artery disease than they are from AIDS. But we still want to encourage people to have protected sex, not share needles, mothers to get tested so, they could get treatment so their kids aren't affected. And blood transfusions, you don't see patients getting HIV from blood transfusions anymore. That's just really not a thing. And in the healthcare setting, there's a low probability of you getting HIV from a needle stick, but there is, you can start the PrEP medication. You can start that medication. They'll put you on the HIV medication. You'll have to go to the ER, get stuck by a needle. They'll draw your blood. They'll draw the person's blood who you stuck yourself, from the needle that you stuck yourself with. And it's a whole process. You'll follow up with employee health. They'll put you on the medication if you choose to have it. A lot of people don't choose to have it, but some do. And they'll do follow-up you through employee health. So try not to stick yourself. And I see the most people that stick themselves are residents in the OR, like surgical residents. They stick themselves a lot. So prevention involves preventing new cases of HIV, and we do that by education, as well as stopping the conversion of HIV to AIDS, because once it goes to AIDS, I hate to say this, you can't go backwards, but there are some cases where you can.
Are you referring to like the diagnosis of like, because she was forever diagnosed as an AIDS patient, even when her CD4 count went back up to like non-AIDS?
Non-detectable, yeah.
Yeah.
Greater than
So
whatever.
are we talking about like not being able to go back as far as like you'll never get your is it like you're never gonna get your CD4 counts above 200 if you have AIDS? I'm gonna have to look this up because I didn't even know
Yeah, this
this.
is
But I
what
knew
I
that.
thought, because that's what you want to do. You want to stop the conversion of HIV to AIDS, because once you got to AIDS, I didn't think that you was going back to those HIV level numbers, but now you're telling me something new. So now I have to do more research.
Yeah, because she was always like, even after she was undetectable, she was never listed as HIV undetectable. She was listed as AIDS
Always listed
undetectable.
as
Like the diagnosis of AIDS didn't go away, even though the CD4 count wasn't below 200.
Gotcha. No, I'm gonna do some more research. But that's a very good question. So just check my discussion post on further research about that. But so her diagnosis of AIDS just never changed.
Correct. Like so everywhere it just got changed to like on paper it was AIDS, but with undetectable levels.
No, that's good to know. So we had 3 very different cases. So we had one case that sounds much like your mother's. He was 48 years old. He was incarcerated, and he didn't take any medication while he was incarcerated because he didn't want the people in the prison to know that he had HIV. So he took no medicine. He came to the hospital because he was COVID positive. He was having shortness of breath, productive cough, and all of those symptoms, right? And his CD4 count was 0, like none. He had
Jesus.
Yeah, and he was walking around smoking. He loved to eat. He had thrush in his mouth. He was happy. He was just a funny guy, but he was diagnosed with AIDS, and he was real thin as well. But he loved to eat. And he loved mashed potatoes. So I'm definitely gonna look into that, because the main thing is you don't want that HIV to convert to AIDS.
So I have a question real quick. I just want to clarify. So if a patient has HIV, it'll progress to HIV and AIDS at the same time. It's either one or the other.
Yes, it's gonna be one or the other.
Okay.
HIV progresses to AIDS, but AIDS never goes back to HIV.
Okay, gotcha.
Yeah, so that was him. And then we had a 30-year-old female. She contracted it at birth, and she was 30 years old. She used to be compliant, and then she just stopped being compliant at some point, and she was in the hospital again for respiratory symptoms, being treated for respiratory infection. They were even trying to rule out TB on her, which it was negative, but yeah, so she said it 30 years. And then we had another guy, he came in for something totally different, for a mental issue, and he has schizophrenia, but they said change in mental status. He still had AIDS. He had a decent CD4 count. His viral load was only 30 copies. And so you want your CD4 count high, greater than 1,000 is what normal people, with immune system have, and under 200 is with opportunistic infections is what they classify as AIDS. And you're under 200, you probably have a high viral load in the 5,000 to 10,000 range, which is high. And so what are some of those opportunistic infections that, well, let's just go to this one right quick. So here's some HIV manifestations. Frequent infections. You might see a female that has frequent yeast infections like candidiasis, fatigue, malaise, weight loss. You may have skin wounds, and when this starts progressing, they may be poorly nourished, have wasting syndrome. They just look thin. I know a physician I work with. He had wasting syndrome bad. He would have like explosive diarrhea. It just was bad. He still was trying to work. But you'll have the presence of opportunistic infections, and your lymph nodes may be enlarged. So this is not an inclusive list. If you read your book, they'll have the different stages of HIV, and it's a great, chart is on page 492, and then you'll have the clinical manifestations and therapies on page 494 to 495. So the girl I told you about that came in with the guy, the 48-year-old, who came in with cough, weight loss, fever. What do you think we need to do with him? What opportunistic infection will they probably try to rule him out for?
Pneumonia or TB?
TB. And so if we think a patient has signs and symptoms of TB and they have a compromised immune system, what do we do? If you're triaging this person, where would you bring this person?
Airborne precautions.
Straight to airborne precautions. You're gonna put them in an isolation room
Yeah.
until we rule it out. And these persons also may have negative tuberculin skin tests because their immune system is compromised, so they can't react to the antigen.
So you just do the chest X-ray then, or how do
No,
you?
and so they'll get sputum, 3 days worth of sputum, early morning sputums. They're gonna do chest X-ray too, but you wanna do the sputums as well. We need to make sure we're ruling it out, and that's how you rule it out as well. You have to do those sputum collections. And if a patient has candidiasis, what do you think? What do you expect them to be taking or have? What medication do you expect them to
An
take?
antifungal.
Antifungal,
Fluconazole.
fluconazole. And also they might have like a magic mouthwash to kind of coat the mouth so it can make it easier for them to eat so it won't burn. And that's a lot of them lose weight because of that. They can't eat because it hurts so bad, so they just kind of stay away from eating. So they'll give them this mixture of Benadryl and Maalox, and they kind of coat their mouth with it and spit it out. And what's another antibacterial that they use for oral infections? They use it prophylactically as well. Y'all may have seen it on y'all floors. Y'all haven't? The chlorhexidine, the Paradex mouthwash, to kind of decrease the bacteria in the oral cavity, because bacteria in the oral cavity can cause pneumonia. When you sleep, that bacteria can go to your lungs and cause pneumonia. And so what signs and symptoms, some kind of talk about that, the signs and symptoms of opportunistic respiratory infections that you might see. Dyspnea,
Coughing.
cough, increased temperature. Yeah, so normal CD4 is greater than 1,000. A CD4 less than 200 with opportunistic infections is considered AIDS. Yeah, but the treatment has gotten to be really good treatments. So I'm not gonna delve into this too much. This is in your book, but these are some of the tests that they use to diagnose HIV. But the two that we're looking at is like your CD4 count. Again, we want that high. Viral load, we want it low. And that's how you know your medication is working. At heart medication is you'll have a low viral load. And when she say undetectable, that means they're not detected it. So the pharmacological treatment, this is the focus of the treatment. This is what the treatment of the medication, this is what they do. And a lot of time I've been seeing Descovy used, and that's a combination antiviral and NRTI medication, Descovy. That's what most of those patients were getting. And so if a patient tells you, like the doctor said, my viral load's low, what can you tell them? They're on medication, they're compliant, and they're like, my viral load's low, but they don't know what that means. So what do you tell them?
Isn't that a good thing?
That's a great thing. Your medicine is working.
Right.
Very good. Your medication is working, because that's what we want to happen. And sometimes this medication is expensive, and if the patient can't afford it, we need to refer them to who?
a social worker or someone who, like a Medicaid specialist or something?
Yes, we need to make sure that they can get their medication. There's some program that's gonna get them their medication, so we do want to, make sure that we're referring them out. And when you're caring for these patients, just like the man who was, in prison and didn't want to take his medicine because he was afraid of the stigma, we need to watch how we, talk to people and how we treat people, and we're not going in rooms with gloves just to turn on a light. And if you don't see blood or body fluids around, like you don't have to put on gloves to put their blanket over them, right? Because they're already dealing with this inside themselves, this diagnosis, and it's scary. Even though they have better treatment, it's still a scary diagnosis to have. So we want to treat everybody with respect and kindness, and also to take care of these patients. What kind of precautions do we need? Is it
The
contact
standard,
precautions?
just standard precautions, because you can only get it with blood.
Standard precautions, and you treat every patient like they got a communicable disease, and you'll never go wrong. Standard precautions. Just want you guys to be mindful of that. Like when we talk about psychosocial effects of disease processes, this is a scary one. Like our 30-year-old who got it from birth, like she was very angry. She was angry. She didn't want to talk. She didn't want to take medicine. And the nurses was letting her refuse her medicine, and she needed her medicine. So when we got there, she was like, "What's this for?" And I'm thinking to myself, "You've been taking this for the last 10 days." But okay. And I talked to her, I told her what it's for, and she just softened up a whole lot. She told the students good luck with school, and she just became, a different person. When people know that you respect them as a person and you care about their well-being, they act different. And you don't want to be the nurse to run out the room. Oh, she refused. Some people I do that, so I ain't gonna tell you no lie. But some people I know need that extra push. Like she needs her medication, right? She's 30 years old. Her CD4 count hers is very low as well. Like she's on the age spectrum of this disease process, and she needs to take her medicine. So take time sometimes, guys, and try to talk some patients into their medicine. I mean, to take their medicines and to be compliant with their treatments. It'll make a world of a difference. Because the day before, she wanted to go home. She wanted to switch hospitals. She didn't want to be there. She didn't know what was going on. Like, she just was not a happy person. And everybody was just kind of ignoring her and letting her refuse her medications. Don't be them nurses. All right. So nursing process, the assessments, of course, we're gonna observe and do a patient interview. And if you are working somewhere where you're in contact with young people who sometimes could be like promiscuous and not safe when you're having sex, we want to make sure that we're talking to them about safe sex. We want to make sure that we're talking to them about getting AIDS diagnosis, or anybody who has at-risk populations. We want to make sure that we're talking to them about getting it tested, and also looking for those cues that maybe they need to get tested. Like people who have I don't work, y'all, so I can't think. What's the chicken pox infection that you get on the skin?
Oh,
It's called varicella.
Are you talking about varicella?
nah, it's shingles.
Shingles. Shingles. So if someone comes in and they have shingles and more than one dermatome, then you might want to tell them to get an HIV test. Like if shingles occur, especially young people, if shingles occur in one dermatome, but if it's in more than one dermatome on the back, like this side and that side, they may need to get an HIV test. So you need to just know those type of cues that might signal to you to maybe this person needs an HIV test. And when you go to the hospital, if you have any kind of infection, doctors are doing HIV tests. You could have pyelonephritis, you get an HIV test. You could have, if they admit you to the hospital for any type of infection, community-acquired pneumonia, you get an HIV test. And especially if you're in a certain age range, you're getting it automatically. All right, so ineffective coping, we kind of talked about that, like being kind and spending a little more time in explaining things. And risk for infection, of course, their immune system is compromised, so they're going, and if the CD4 count is low, they're going to be at increased risk for infection for sure. That less than body requirements, we have to make sure they don't have thrush. If they do, we need to be treating that thrush, or candidiasis, oral candidiasis. We need to treat that so that they can eat. Knowledge deficit, anxiety, and fear. We need to make sure people are getting tested and letting them know that there's treatment and there's, support groups and there's treatments and people are living longer, healthier lives. And I think if people knew that, then more people will get tested, right? But non-adherence to medicine, to their treatment regime can cause an increased morbidity and mortality. So we need to make sure that they're taking their medications. And so if someone has HIV, what medication, what food should we tell them not to eat?
Like undercooked meats and
Right,
fish.
raw meats and right, raw vegetables, uncooked meat, oysters, anything that can cause, that has bacteria, we should not be giving them, or we should educate them not to take. And so you can kind of look through the plan and the implementation. So you know we want to do prevent secondary infections and promote medication regimen. All of those things are very important when caring for our patients with HIV or AIDS. And evaluations, this is what we want to occur. Correct? Any questions about HIV, AIDS, or anything, just leave it in the discussion board. Thank you guys. Make sure you guys finish strong. It's been a pleasure.